Hello and welcome to Fine Print, Rules for Exchanging Behavioral Health Information in California. My name is Connie, and I'll be in the background answering any WebEx technical questions. If you experience technical difficulties joining the WebEx session, please dial 1-866-779-3239. Please note that as an attendee, you are part of a larger audience. However, due to privacy rights, we have chosen not to display the number or list of attendees to everyone on the call today. All attendees will be in a listen-only mode throughout the duration of today's call. As a reminder, today's call is being recorded. We will be holding a Q&A session at the conclusion of today's presentation. You may ask an online question anytime throughout the presentation today by simply clicking on the question mark icon located on the floating toolbar or the Q&A panel on the right side of your screen. Please keep the Send to default as all panelists. With that, we invite you to sit back, relax, and enjoy today's presentation. I would now like to introduce your first presenter for today, Catherine Tier, Associate Director in the California Healthcare Foundation's High Value Care Program. Catherine, you now have the floor.
Welcome, everyone, and thank you for joining today's webinar on the rules for exchanging behavioral health information in California. We are really glad to see so much interest in this topic, and we apologize for any confusion you experienced in getting here. As we said by email, the interest in this webinar far exceeded our expectations, which is why we had to move to a new and roomier webinar site. This webinar is a follow-up to a publication of the same name, which many of you have seen and which is available on our website. And as mentioned, the webinar is being recorded, and you will have access to it in a few days on our website, chcf.org. A few words about the California Healthcare Foundation. CHCF is a nonprofit grant-making philanthropy based in Oakland, California. CHCF was founded in 1996, and from its inception, CHCF's strategy has been one of engagement, collaboration, and partnership with key health players in state and local government, employers, providers, consumer groups, patients, and other foundations. I'm Catherine Tier, Associate Director of CHCF's High Value Care Program. As you all know, the care that many patients receive doesn't reflect what they want, what we know works, and what provides value. The High Value Care Program at CHCF supports policies and care models that align with patient preferences, are proven effective, and are affordable. One stellar example of this is the integration of physical and behavioral health care. We know that in Medi-Cal, for example, people with diabetes who also have addiction and mental illness have 8 times as many annual emergency department visits and 2.5 times the annual Medi-Cal spending as people with diabetes alone. Integration of care for these individuals can improve their well-being and their outcomes. Over the last decade, thanks to the work of many of you on this call, California has made great efforts to advance behavioral physical health integration on many levels, at the state, in the counties, and at the health plan and provider levels, and that work is accelerating. One thing that remains universally challenging, though, is information sharing. We have heard from many of you that you are uncertain about what information you can share and how to share it. Some of those challenges are technological, EHRS that don't talk to each other, for instance. Some are cultural, and some are legal. And it's for this reason that CHCF earlier this year commissioned the fine print paper, and we are grateful to have a great panel here to talk about that paper and other issues related to sharing behavioral health data to improve coordination of care. I want to introduce our speakers. Before I do that, though, an important disclaimer. This is an educational program, and the information that the attorneys on our panel provide is not legal advice. Similarly, the information from our clinical folks is not medical advice. We'll begin with an overview of federal and state law, hear about an on-the-ground implementation in Alameda County, get a state perspective from Cal-OHI, and then transition to a question and answer session when all the speakers are done. Our speakers in order are Bob Belfort, who is a partner in Manatt, Phelps & Phillips, based in New York City, focusing on the representation of healthcare providers, health plans, and other healthcare companies on regulatory and transactional matters, including HIPAA and other privacy laws. Bob was a co-author of the fine print paper. Kathleen Clannon is Medical Director of the Alameda County Healthcare Services Agency and has been a physician in the Alameda Health System since 1984. She's Assistant Clinical Professor of Medicine at the University of California, San Francisco, and has a distinguished career in HIV services. Jennifer Schwartz is Chief Counsel of the California Office of Health Information Integrity, which works to ensure the safe movement of health information to support better health and outcomes for Californians. Jennifer has extensive knowledge and experience in healthcare law, having worked for the Department of Corrections and Rehabilitations before joining Cal-OHI. And finally, Mary Rainwater, who will be moderating our Q&A session, is a consultant to nonprofit and government health, mental health, and philanthropy organizations and academic institutions. She is an LPSW with extensive expertise in the areas of behavioral health, delivery of integrated health services to underserved communities, and designing and developing programs for special populations. So without further ado, I will introduce Bob Belfort, who will do the first part of our program. Bob?
Thank you, Catherine, and thanks to all of you for participating today. As Catherine suggested, I'm going to be trying to provide the legal framework for information sharing by behavioral health and other providers, talking about the overlap between state and federal law. If we could move to the next slide. So what we try to do in the paper is really try to provide kind of an overview of the interplay between the primary state and federal laws that regulate both mental health and substance abuse information. On the federal side, the two main laws that we're dealing with are HIPAA, which I'm sure most, if not all of you, are familiar with. And HIPAA is broad in scope. It basically covers all protected health information maintained by providers, plans, and their contractors. And then a much narrower but very significant set of regulations at the federal level, often referred to as the Part 2 rules, which govern records of federally assisted alcohol and drug abuse treatment programs. At the state level, we have the Confidentiality of Medical Information Act, or the CMIA, which is somewhat analogous to HIPAA in that it's broad in scope and covers health information generally. The Lanterman-Petras-Short Act, which applies to the records of certain mental health providers, and then California regulations that are parallel to a large degree to the federal Part 2 rules that govern substance abuse treatment providers. One of the questions that often arises is which of these laws applies and which ones do we have to follow? What if there are different standards under different laws? And the basic rule is that whichever law makes it more difficult for you to do what you want to do is the law that you have to comply with, which is a somewhat funny way of saying that you have to comply with the more stringent law. So none of these laws preempt each other. To the extent any other law is more stringent, you have to comply with the highest confidentiality standard. Can we move to the next slide? So what I wanted to do was to try to just briefly go through each of these primary laws and regulations to talk about what their scope is and what their basic rules are so that you can understand which generally present issues in information exchange among providers and which do not, because I think there's often a lot of confusion about that. HIPAA, which is the statute that people are most familiar with, is, as I indicated before, it's very broad in scope. It covers most healthcare providers and health plans, healthcare clearinghouses, which are entities that are sort of intermediaries between providers and plans performing certain functions, and what are referred to as business associates, which are essentially vendors of providers and plans that have access to protected health information. Unlike most of the other laws that we're going to talk about today, HIPAA applies the same rules to all types of information so that information about a broken leg is basically treated with the same sensitivity as information about substance abuse. The only exception to that standardization is with psychotherapy notes, which are treated with a much higher standard under HIPAA, but psychotherapy notes have a very specific definition, which generally is not that relevant in institutional context, and mainly they're notes that are kept separately from the basic medical record that's used for billing and other institutional purposes, so they're usually more commonly found in a private practice setting. HIPAA has very broad exceptions that cover treatment payment and what's referred to as healthcare operations, which includes, among other things, care management and quality improvement. And so for the vast majority of disclosures that occur among providers participating in various types of networked or coordinated arrangements that are designed to improve care, coordinate treatment, engage in quality management, things of that nature, generally HIPAA is not an obstacle because there are these broad exceptions. And HIPAA is also a fairly easy statute to deal with because when authorization is required, HIPAA permits a very broad authorization that can refer to a class of providers. So for instance, you could have an authorization form that covers any providers participating in a particular program or exchange without having to specify the names or identities of those providers. So in my experience, while there's a lot of reference made to HIPAA, usually HIPAA is not the obstacle to information sharing for treatment or quality improvement or care management purposes. Move to the next slide. In contrast, of all of the laws and regulations that we'll talk about today, the Part 2 rules by far present the most significant challenge. On the one hand, the rules are narrowly focused on a very discrete class of organizations. They only apply to federally assisted alcohol and drug abuse treatment programs, and there's a lot of confusion about what that term means. Essentially, there's two components to that definition. First, you have to be federally assisted, which is broadly defined to include any type of federal financial support, which could include federal grants from SAMHSA or other agencies, reimbursement by Medicare and Medicaid, tax-exempt status. So in my experience, there are very few providers that are not federally assisted, although there may be private substance abuse treatment facilities that don't take Medicare or Medicaid and are for-profit that might be outside the scope of the Part 2 rules. And then the second component is that it has to be an alcohol or drug abuse treatment program, and that is defined to mean a provider that is licensed to or holds itself out as providing specialized substance abuse treatment. And this is a very important piece of the definition because the records of general medical providers like a hospital emergency room that might treat individuals with substance abuse are not subject to Part 2 if they don't hold themselves out to the community as providing specialized substance abuse treatment. What makes this a little more complicated to deal with in many settings, though, is that when a program that is subject to Part 2 discloses records to another provider pursuant to the patient's consent, those records continue to be protected. So providers that aren't directly subject to the Part 2 rules may still have Part 2 information in their files, and that information still needs to be protected. And the rules apply to all patient records of those programs, including the identity of the patient served, even if no detailed information about their diagnosis or treatment is being disclosed. And what is most challenging are two things. Number one, the exceptions under Part 2 are very limited. There is no broad treatment exception or exception for payment or healthcare operations. The major exception is, in the clinical context, is disclosures for medical treatment and medical emergencies, and that's obviously quite narrow and doesn't apply in most of the cases that providers are involved in some sort of information sharing. The other big hurdle with Part 2 is that unlike HIPAA, SAMHSA has interpreted these rules as requiring a very specific consent that names the individual or entity that is receiving the information. So reference to a class of organizations or individuals without naming them is not deemed adequate by SAMHSA for purposes of complying with Part 2. Can move to the next slide. The CMIA, I won't spend a lot of time with except to say that it's very similar in scope to HIPAA and also similar in the sense that a broad consent is generally going to be permissible, but usually you can fit within an exception under the CMIA, and like HIPAA, it's not usually an obstacle to data sharing for clinical purposes. Next slide. So on the state level, in addition to the CMIA, you have the LPS Act, which I referenced earlier. This applies to federal, state, and county mental health hospitals, institutions that treat involuntarily detained patients, residential mental health programs, and outpatient mental health providers that participate in certain government programs, and includes basically all of the mental health information that's maintained by these facilities or programs. There is a little bit of ambiguity, and like many state laws, which is the case not only in California but elsewhere, the laws were enacted many years ago and were not drafted with the current data sharing framework in mind. It does permit disclosure between qualified professional persons for treatment purposes. And so there is certainly a reasonable interpretation that this was basically intended to permit institutions to share information with one another for treatment purposes, but in the paper we did get some feedback from providers that they were concerned that disclosures outside of a limited number of professionals to individuals who worked at mental health institutions but weren't necessarily licensed providers might not be permitted. And as we'll talk about at the end of the presentation, it may be helpful to clarify the meaning of that provision to create some comfort about its scope. Move to the next slide. And then finally, the Health and Safety Code section here, similar to the Part 2 rules, doesn't have any exceptions other than medical emergencies and covers many of the same providers that would be subject to the federal rules, although it may also cover some providers that are outside the scope of Part 2, which would extend the very stringent protections to a wider class of organizations. The nature of the consent that needs to be obtained is not specified in these rules, but given the fact that there's large overlap here between these providers and the Part 2 providers, generally a specific consent that lists the individuals or entities receiving the information would have to be obtained. Next slide. So trying to put this all together, what does this mean? I think, as I said before, from a HIPAA standpoint, generally, to the extent there's a belief that HIPAA is an impediment, it's usually based on a misunderstanding of HIPAA and a lack of understanding about the broad exceptions that exist under the law. There is a significant issue in terms of Part 2, as we've talked about, not only because of the limited exceptions that only apply in medical emergencies, but also because of the demanding requirements for consent and having to list the specific providers who are accessing information. So one of the issues that we've confronted in many broad health information exchanges is that providers want to obtain a consent that would permit disclosure to all of the organizations that participate in the HIE. Those organizations, there may be scores or hundreds of them. They may change over time. It's not practical to get a consent that lists them by name and is constantly updated. And so obtaining this kind of broad consent that covers the entire exchange, while permissible under other laws, is not sufficient from a Part 2 standpoint. As we mentioned before, We also heard about ambiguity in the LPS Act that has left some providers uncertain about whether there is a broad treatment exception there. And the last thing, and I think Catherine referenced this in her introduction, is that the barriers to integration of behavioral health and physical health information are not entirely legal. And what we learned from researching the report is that even when information sharing is legally permissible, there may be other barriers. The barriers could be technical, where some providers don't have electronic health record systems that can easily exchange information, or the systems of various providers don't talk to one another. This has been a huge problem in terms of interoperability, with the government having funded EHRs that really don't talk to one another and are siloed, and there continues to be a lot of focus on this issue at the federal level. And then lastly, operational challenges where providers may be reluctant to take on additional obligations and modify their workflows in order to share information. Next slide. And so the last thing that we tried to do in the report is, given the legal framework and the barriers that appear to flow out of that, what are potential pathways to improve information sharing? And we identified 4 different areas. One, which we've mentioned before, is trying to create clarity where the law is uncertain. Unfortunately, that clarity already exists at the Part 2 level, so I don't think the issue there is ambiguity. But with the LPS Act, there could be a benefit through clearer guidance and interpretation, particularly in the area of exchange for treatment purposes by mental health organizations, which I think could eliminate some uncertainty among organizations interested in information exchange. Federal efforts to promote interoperability could help relieve some of the technical barriers that exist in terms of preventing information exchange. There is definitely an effort underway by various organizations to try to get SAMHSA to reconsider its position on Part 2, particularly the exceptions are probably not something that SAMHSA can tinker with very much because they're pretty clear in the regulations. But you know, one issue is in terms of what the consent form has to contain and whether more flexibility under the existing rules is possible in terms of having more broader consent forms that can describe the recipients of information in a more general way. And then lastly, looking at data sharing models that are more effective given the constraints, particularly of Part 2. This is something that we've spent a lot of time on in New York, where we've been working with the statewide health information exchange here. It's very hard to be compliant with Part 2 and have a consent obtained at the disclosure level because the disclosing provider does not have the names of all the organizations that might ultimately access the information, and so it can include them on the consent form. But what's being explored here is what we call a consent to access model, where essentially records could be uploaded into an exchange without patient consent under what's called a qualified service organization agreement, which is equivalent to a business associate agreement, where a vendor holds the information, doesn't disclose it until consent is obtained, but at least has it in a place where it can quickly become accessible. And then when a provider wants to access the information, the provider can obtain a consent that names that provider as the recipient and would be able to do that just on their own behalf without having to get a broad consent that covers multiple providers. And so while there are still challenges with that model, it may be a path toward more effective information sharing of substance abuse information until such time as perhaps the law gets reconsidered and loosened in some way. And so I think I will stop there and turn it over to Kathleen for the next section of the presentation.
Hi, everybody. So as I assume you know, Alameda County is in the northern part of California, includes the cities of Oakland and Berkeley. We have about 1.6 million residents. And next slide, Catherine. The we, in the what we are doing, is the Alameda County Healthcare Services Agency. Healthcare services includes, we contract for care of people, the remaining uninsured, and also work with the safety net medical care to improve and to encourage integration of behavioral and physical health, et cetera. We also include the behavioral health system, including specialty mental health and also substance abuse treatment, in particular for low-income folks in our county. So what we're doing is that since last year, we've been sharing specialty mental health encounter data with the assigned primary care medical home of our patients. What that looks like is we receive claims data essentially on a monthly basis in which the specialty mental health providers say we saw patient X for a visit. We also get information from psych emergency and also the psych inpatient about our patients. We then sort that information by the patient's medical home, and we post it into a portal that is accessible by the medical homes. And they know, we push out an email to them to tell them that updated information is available there. We then expect them and support them to pull down that information, and as they do in parallel with their physical health information about similar encounters, that they will then have a workflow to make sure the appropriate professionals are informed within the clinic and that there's outreach to the patient. So we are so far doing this with our health pack patients only, which is, those are the data that we essentially own. That's our medically indigent patient program. We are working, though, on getting the Medi-Cal data included, working with our local plan to start. We are also doing a lot of work to facilitate the subsequent pieces, the outreach to patients, so that we're using this data exchange to improve their health. And we're monitoring the workflow processes that the clinics have, looking for kind of best practices and trying to help them exchange information with each other about, hey, what happened when you use this information, how'd it go? And we're working hard with the specialty mental health providers to try to get them used to getting questions or contact coming to them from the physical health side. So next slide, Catherine. So that's what we're doing. And going backwards to how we got here, the behavioral health folks have a 10 by 10 initiative in our county focused on improving the lifespan of people who have severe mental health issues. And that was one of the drivers, because we realized that we were pretty sure a lot of the folks who were involved in the specialty mental health programs were not really seeing physical health providers frequently, and that there was no way for us to really track that and put people together unless we could share data and see where those shared patients were being seen and where they weren't being seen. Then there was also a lot of frustration on both sides, as it were, the physical health and behavioral health side, about disconnects in care. We heard anecdotes, and unfortunately only anecdotes because we weren't sharing these data, but we heard anecdotes, for instance, about patients who would be seen in specialty mental health, would miss an appointment, were at their physical health provider with a bottle that was empty and said, I need this refilled, and that the physical health provider said, what, I don't know what this was prescribed for, you have to go back to your behavioral health provider to get it refilled, and then the patient would bounce back into a psych ER. The behavioral health folks were very frustrated about what they felt was lack of kind of communication and cooperation from the physical health side. And then there were similar kinds of concerns on the physical health side. That really helped, the fact that it was a pain point for people in our community helped us kind of get people together for the purpose of doing something different about it. Next slide, Catherine. So we identified 4 kind of steps or areas of work. The first one, getting permissions, is what some of what Bob has been talking about. We also knew that we were going to need to make our data systems talk together. The workflows, the making sure that something happens with these data so that it makes it worth it to do the work so that patients' care is improved. And then we also have done a lot of work investing in the relationships between the mental health and physical health staffs. I think we all know it's sort of a truism in business and other places. We say it's all about relationships, but we frequently don't actually invest in that. And we have been doing that, really investing in the human side of that since the beginning. These 4 steps can be pursued actually simultaneously. They aren't necessarily dependent on each other. And that's the approach that we took. We worked on all of them at the same time, and each of them kind of influenced the others. Go ahead to the next. So here's the getting permissions. We started out by, as it says here, swiping a tool that we found that had been developed from the San Francisco Department of Public Health. I think we're in a second going to be able to see a full-size version of that, and it's also in the paper. This form, as you can see, is designed really for providers to read, and it has specifically over on the left-hand side what is the kind of information we're talking about, then the who may disclose it and who may receive it, and that category also talks about kind of why, for what purpose. This tool impressed me because it seemed very clear and it's very boiled down. It's this one page. And it was something that really kind of answered the questions that our folks had. So we floated this to County Council along with sign-off from both the behavioral health leadership and the physical health leadership on our side to say we have as a strong policy intention that we will be doing this data sharing. We need your help to help us figure out how to do that. So County Council signed off on this policy document, and we then were able to begin using it and sent it out with our first sort of communique saying that these data were going to start being shared. There was a significant amount of resulting excitement of various sorts, including, some kind of hot meetings in which people said things like, "You're just going to ignore HIPAA?" As Bob was mentioning, people kind of tend to pull HIPAA like it was a gun to warn away. It's not a very nuanced understanding that people have typically. So there was definitely some resistance on the part of various folks, not so much from patient communities as from provider communities. Let's look at the next slide. I suspect that these positions are going to be familiar to you all. On the primary care clinic side, they mostly worried that we were essentially giving them the dreaded unfunded mandate, that we were asking them to do something new. So in receiving this encounter data, what did we really expect them to do with it, and how long was it going to take them? That was their worry. And on the specialty mental health side, they were in a very principled way, worried about the impact of a potential disclosure on their patients. And at a deeper level, they were just worried about whether their patients were really and truly welcome in primary care clinics. And the concern, including some scholarly papers they brought forward, that clinics really may not be always a welcoming environment, was really part of the heat of what was coming from the provider side. So there was no real magic in working through that. We decided, and I'll be interested in what you all think about this, we decided to make the decision at a leadership level and put the new system in place and begin sharing the data before having all of the stakeholder meetings, with the expectation that it would take us many years to get agreement from all our different stakeholders. And so we made the decision, implemented it, and have since then, over this past year, been talking with people about it. And I believe that turned out actually to be a better way of approaching it for us. But I understand that people may disagree about that. So we've been talking about the permissions. The next thing is making the data systems talk to each other. Next slide, Catherine. So we really already had a system in place in which the data systems really aren't talking to each other directly. What's happening, as I said, is that we're posting lists that we create into a portal. We already had that established for the physical health side, so it was directly parallel, and that meant that technical issues were easy. So really, from my point of view, what we did, next click, Catherine, was we took the Jean-Luc Picard, back one. We took the Jean-Luc Picard approach and just said just told our technical folks to make it so, and it really did not take very long. Getting EHRs to talk to one another is very much more complicated. Here we're talking about primarily administrative data, encounter data, claims data, And because it goes in batches on a monthly basis, the technical issues there are simpler. That was one of the trade-offs we made for being able to do this without extensive consent and security issues. So permissions, making the data systems talk to each other. The next one is developing the workflows. Next one. So at each of the medical homes, we already had a SPOC, a single point of contact, who was someone that we worked with around on the physical health side around informing people when their patients had been, informing the primary care clinics when their patients had been hospitalized. So we asked them to now designate a data SPOC, a new person, or could be the same person, who would be responsible for problem solving the entry of these new data into their institution, mapping out a workflow that we would see and be able to evaluate, and then helping within their organization to actually push along the agenda that the data would be used and wouldn't just become dusty in its repository. So the medical homes each were able to identify the SPOC because we'd done it before with our other data. That wasn't too hard. And then we actually put a lot of work into convening the SPOCs. We have had physical meetings with them, and then we have monthly monthly telephone calls with them in which they share information with one another. Frequently, they solve each other's problems. And we get a chance every month to give them another infusion of reminding them about what is important about this and the specific, there are specific people who are suffering as a result of our not connecting this information. They also really, really appreciate, as operational people inside the clinics, they really appreciate the opportunity just to meet one another telephonically. And I think that's a secondary gain from the whole system. Then we also work with the medical directors on the clinical end to make sure that they know that, in fact, there is an expectation, as they feared, that there is an expectation from us as part of their contract for care that they're going to reach out to patients who've been seen in psych ER, psych hospital, or specialty mental health. They'll reach out to the patients, and they'll reach out to the patient's provider. That back and forth helped us make the information more useful. As an example, the report that goes into the portal has the patient's name and identifying information and says patient was seen at X, at Man's Best Mental Health Clinic. And originally we just put down the name of the mental health, especially mental health clinic where they were seen. And people said, hey, if you added a telephone number for the clinic, then we could just take this report and use it as a panel report essentially to contact the mental health provider. So it actually was not simple, but we were able to make it possible to put those telephone numbers down. So just trying to make our lists more and more useful to the people who had them in their hands. So as much as we could do here in the workflows, they were all very different, but we were looking at them so that the clinical people were having control of the information and that they were doing something with it. So permissions, the data systems, developing the workflows, and then the last thing, next slide, is the investing in relationships. We put all this stuff in place, and I think at month 9 or something like that, we did a survey and found out that the primary care providers were really still not calling their mental health colleagues. We talked to the mental health folks, and they said, no, not getting any phone calls. And by the way, didn't you say that was going to happen as a result of this? So some of that is, you all will recognize, is the difficulty that people, it's hard to call when you're seeing patients, one after another. And some of it is that there was still this sense of a barrier in them versus us. So we invested in this group, the PCPCP, the Primary Care Psychiatry Consultation Program, with 4 psychiatrists who then do this kind of circuit riding thing. They go from clinic to clinic. You can see the flyer there. And because they are in the behavioral health system, but are visiting the primary care clinics, they act as kind of a human bridge for the information to get from one, to help people problem solve and get used to the new habit of contacting and coordinating with one another. We are working on a technology fix for testing with one clinic and one mental health provider, a direct messaging that will allow, it kind of looks like an email between the sites. That'll get a lot easier as the mental health sites get off paper and onto an EHR, but for now that's our best technology piece, and we'll see whether the technology actually helps or whether it really comes down to the that it's hard to get people to reach out to care for people and connect to people they don't know. So my last slide is thinking about what it is that has been successful and not so much about our work. The SPOC network has definitely been tremendously successful. It's cheap. People like it once you get them going, and it has resulted not only in making this process work, but other processes in which we're trying to make integrating across the care system. Having human beings who are bridging the divide, you cannot short-circuit that. We need to look at a face and have a sense of who the human is on the other side. And then we built on our our physical health analogs in terms of the data sharing we were already doing, and that meant that it was easier for people to understand. The challenges you can see there, getting the providers to talk to each other. The Medi-Cal data has been very slow to get that piece going. Even though we have all the permissions in place, it's just a different animal. And we're looking there to move beyond claims data, administrative data, to actually more real-time encounters. Because we focused on encounters in order to avoid some of the difficulties that Bob was talking about, we don't transmit any real medical records aside from the name of the individual and where they were seen. But we do have access to medications and labs, and the providers on each side, everybody taking care of the patient, would really love to be able to see those lists. So we're working on that piece next and trying to understand if it's going to change whether or not we need consent from patients. So that's it from me, and I'm going to turn it over now to Jennifer.
Good afternoon. Thank you, Kathleen. My name is Jennifer Schwartz, and I am the Chief Counsel of the California Office of Health Information Integrity. If you haven't heard of our office, it's probably because we're a small office in the California Health and Human Services Agency. Next slide, please. Cal-OHI has statutory authority over state entities in the executive branch of government that are required to comply with HIPAA. We have authority over monitoring state agencies' compliance with state and federal privacy, security, patient rights, and transaction code set laws and regulations. This includes enforcement agencies. We also have the authority to create statewide policy and development. We recently developed and implemented the Statewide Health Information Policy Manual, the SHIPM. The SHIPM integrates and standardizes the interpretation and application of California and federal laws, regulations, and policy. The SHIPM does apply to enforcement agencies, and I'm sure there's a lot of interest in the SHIPM at this moment, but I do need to say that the SHIPM includes some very specific laws that apply only to California state agencies. So before you rush to implement all of the policies we have drafted in the manual, I would highly recommend that you first look to see if it's applicable at all to you. We do have the authority to represent the state of California in liaisoning with the federal government. So in terms of the Office of Civil Rights Audits for HIPAA compliance, or in terms of making comments and providing the state's position to the federal government on notices of proposed rulemakings and items like that. Next slide, please. So I'd like to speak to state policy. I know there's a lot of interest in how the state develops its policy. But first, I'd like to sort of explain there are two things to really talk about. First is a way to implement law, so in other words, a course of action. And the second is a guiding principle. State policy as a course of action is essentially that state agencies are responsible to implement the law. We don't create the law. The legislative branch of government does that. Our responsibility is entirely on implementation. This means we need to interpret it with the information that we have and then determine how to apply it to our business practices. As the elected head of the executive branch, the governor has the ultimate policy-making authority for the executive branch, and we must implement the law consistent with his vision, along with our stakeholder input. If the governor is silent, then we look to in larger part to our stakeholders and to studies for input. For example, our statewide health information policy manual did have input by the public. We have a team of representatives called the POST, the Policy Steering Team, which has representatives from the healthcare industry, health information exchange industry, health technology industry, the government, patient advocates, privacy advocates, and those sorts of folks, such as, for example, the Hospital Association. We also had input from the pharmacy industry representatives as well as general members of the public. We received input on the different policies that were in interpreting and applying the law, and then we made changes to reflect any kind of trickle-down effect that may be in a way that was not intended. Those of us who are not elected, we still have a duty to listen to the public. So I realize that perhaps that is something that you didn't expect me to say, but I have not been elected. I need to listen to public because we have a duty to hear what the public has to say when we develop our courses of action. State agencies, we develop regulations as a main way to mandate behavior through the interpretation and application of the law. Regulations take often over a year to adopt, and so policy as a course of action is based on the law. That action, that plan, is really about moving from seeing what the law says into doing what the law says. However, policy as a guiding principle is influenced by society changes in thought, research, evidence, and experiences. This is about changes in understanding and philosophy. State agencies have to balance policy versus the law. Policy as a guiding principle changes faster than the law. So we have a duty to both look and see what those changes are and then also comply with the law. So we attempt to adopt the new guiding principles that our stakeholders show are effective in addressing issues or in serving the public within the confines of having to follow the current structure of the law. Next slide, please. In order to protect patients from the stigma and to encourage the full and comprehensive use of behavioral health services, the previous guiding principle was to super protect or specially protect. The laws that Bob Belfort spoke about earlier reflect this guiding principle through the limitations on sharing the data. This encourages a separation model of healthcare, which isolates the behavioral health from the primary care. This is an example of how policy as a guiding principle works with policy as a course of action. However, we have a new guiding principle founded on evidence-based studies showing a larger improvement to health outcomes with integrated care models. But note that our laws are still reflecting the old guiding principle of protecting and separating. Health information technology enables sharing at a faster rate. It's also effective, but it doesn't fit well with the old legal framework. This is because the laws were enacted both before technology was developed, and the laws intentionally do not encourage sharing. Next slide, please. I'd like to bring up some recent legislation about privacy and patient information. There have been two chaptered bills that show you sort of the absence of new laws that reflect the new guiding principle of integrated care. AB 1337 is really about attorneys obtaining their own clients' medical information for lawsuits. And AB 503 is really about ensuring that emergency medical services information is received by EMS providers so that they can do quality improvement assurance. But recall what I said about state agencies implementing the law but not making the law. Since we're responsible to comply with the law, it's difficult to implement the new guiding principles when the law's intention reflects the old principles. The absence of new law about expanding integrated care and supporting integrated care means that we still have a difficulty complying both with the new guiding principle and with the legal framework. Next slide, please. We need to update privacy laws for the current technology. So electronic healthcare records, an example of something that we should clarify is to clarify or update the law to allow for maintenance of electronic health records by vendors outside a behavioral health entity. Another example of what we need to clarify is that we should clarify that health information exchange is an appropriate way to move behavioral health information. Another would be authorizations. We need to clarify that electronic signatures are acceptable. For example, they're acceptable in other areas such as real estate signatures. I don't know about you, but I think that signing a ton of paperwork, 50 pages of paperwork to purchase a house and to receive a mortgage is far more complicated than deciding whether or not I want my other doctors to receive my health information. You can do electronic signatures in a real estate transaction, but the law is unclear as to whether or not an electronic signature is acceptable for an authorization for the release of health information. We need to clarify and expand the use and disclosure of 42 CFR Part 2 covered information and Lanterman-Petra Short Act covered information and records, so that new guiding principle frees state agencies and providers to act in a way that mitigates their liability. We also need more discussion about how privacy laws support care rather than are a barrier to it. Privacy laws were never meant to prevent or hinder care, but to prevent embarrassment or discrimination to the patient. When new models of care and methods of providing care are discussed, privacy should be included to ensure that new grounding principles can be supported through privacy laws. I know this is going to sound controversial, and it is, but I'm going to put it out there nonetheless. We do need to ask ourselves whether we still need special protection on certain types of information. Do we still need to specially protect certain conditions, diseases, illnesses, and injuries when we already have protections on this type of information? So as a method of effectiveness, the conversation perhaps should start there and then move on to what do we need to change, if anything, once the public has weighed in on whether or not they agree with the new movement towards an integrated care model. Thank you very much.
Thank you, Jennifer, and thank you to all the speakers. We're going to move on now to a question and answer session, and Mary Rainwater will be moderating questions. A number of you have already submitted some through the Q&A tab, and we encourage you to continue to do so. We probably won't get to all of the questions. We'll get to as many as we can, but part of the purpose of this webinar, in addition to providing information, is also to seek input from the audience as to what sorts of things you need to know more about. So we encourage you to ask questions through the Q&A, and as I say, we'll get to as many as we can. A few people had asked whether we will be posting slides and other material, and I want to assure you that we will, in addition to posting the recording of this webinar, we will put up the PowerPoint slides as well as links to, for instance, the chart that Alameda County has been using and to Cal OHI's State Health Information Policy Manual. So you can look for those, and we will be sending links after the webinar. So Mary, I will now turn it over to you to ask the first of the questions to our panelists.
Okay, great. Thank you so much, Catherine. And I also just want to thank each of our panelists for such terrific presentations, and all of you for submitting questions. And as Catherine said, we'll try to get to as many as we can. Before we start, I just want to sort of offer a comment and an observation that I hope all of you, sort of the takeaway from today, after listening to everything you've heard today. And this comes from working in California and also nationally on behavioral health integration for quite a while now. You know, it's pretty clear that it's still not a perfect and exact science how we're going to do this data and exchange of information and sharing privacy issues. And it's not going to be clear for a long time, and will always have some murky areas and some risk to it. So I hope what people walk away with today is really sort of the kind of can-do attitude that Alameda brought to this, and really that notion that you can't take no for an answer, and you have to just keep kind of chipping away at these issues until you can get to what's in the best interest for the populations that I know we all want to do great care for. So, you know, and at the same time trying to clarify the laws and the regulations and how they apply to all of our settings. So that's our hope for one of the takeaways today. And I want to kind of go back, Bob. There was a lot of questions that came up as you were talking, not surprisingly, about 42 CFR. So I want to kind of focus us back on that for a couple minutes. And several of them are talking about what constitutes a psychotherapy note. So maybe you can talk a little bit about, so what exactly is a psychotherapy note? How does that fall under 42 CFR? And another question dealt with if a mental health specific service has a medical record content referring to substance abuse treatment, is it or is that not something that would be subject to 42 CFR?
Sure. So regarding the first question, the concept of psychotherapy notes is a HIPAA concept, not a Part 2 concept.
Okay.
Part 2 regulates substance abuse treatment information, not mental health information, and the concept of psychotherapy notes is not referenced anywhere in Part 2. So the issue of psychotherapy notes comes up under HIPAA, where, as I mentioned before, generally HIPAA has a single standard that applies to all protected health information, but there is a particular exception for psychotherapy notes, which, unlike other types of health information, cannot be exchanged for most treatment, payment, or healthcare operations without the authorization of the patient. And a psychotherapy note is defined as the notes of a mental health professional about therapy sessions that are maintained separately from the rest of the patient's medical record, which might be used for billing and other purposes. So, for instance, if a private practitioner wants to create a medical record that supports billing to insurance companies, they can include things like the diagnosis and the history of the sessions and any medications that might have been prescribed and other basic information which would be sufficient to support the medical necessity of those services for reimbursement purposes. But if they didn't want the insurance company, if the insurance company requested the medical records, they didn't want the insurance company to see the notes that the therapist was making regarding sessions that went into more detail about what the patient was saying, they could maintain those notes separately from the rest of the medical record, and they would not be required or permitted to share those records with the insurer without the patient's authorization. So in my experience, psychotherapy notes are usually, if they exist, they tend to exist more in private practice settings where practitioners might decide to keep separate notes. In an institutional environment, most of the clients I work with don't want individual clinicians to have their own records that are separate from the institutional records, and so typically they don't maintain a separate set of psychotherapy notes. They just have progress notes that are basically the record of all patient encounters. But there may be institutions that do permit or encourage that, but the key notion is that they have to be separate, physically separate from the rest of the medical record, and generally they would include more detailed information about encounters rather than the basic diagnostic and treatment information. I've now forgotten the second question because I talked so long. I'm sorry, could you repeat the?
Yeah, it was really more specific to if a mental health specific service has medical record content. Yeah, go ahead.
So, so in terms of Part 2, the Part 2 rules apply to federally assisted programs. So if you're not a federally assisted program, like you're the emergency room of a general hospital, or you're a primary care physician that occasionally provides advice to patients about substance abuse problems, none of your records are subject to Part 2. Even if a patient comes through the emergency room of a general hospital with with an overdose and goes through detox or something like that, those records are outside the scope of Part 2. So Part 2 only applies to the records of federally assisted programs. Generally, everything that those programs maintain will be subject to Part 2 because the program is being defined as a specialized substance abuse treatment provider, so its records generally involve substance abuse treatment. So I think, one of the confusions is that just because you have some substance abuse information in your records doesn't make you subject to Part 2. You have to meet the definition of a federally assisted program, which generally means you have to hold yourself out to the public as being a specialized substance abuse treatment provider.
Okay. So then there was a follow-up question saying that if many communities are trying to avoid opioid prescription overdose, given the Part 2 Fed and state confidentiality issues, how can hospital emergency departments communicate concern to primary care or other providers related to suspected opioid treatment? Would that fall into what you were just talking about there?
Well, if it's a hospital emergency department, they're not going to be subject to Part 2, so their reporting is going to be analyzed generally under HIPAA. If they're making the report for reasons other than treatment, payment, or healthcare operations, which, arguably would be the case, then typically they're responding to some state mandate to report. So if there's a state-mandated reporting obligation of some kind, that requirement is going to permit disclosure under HIPAA because HIPAA permits any disclosure that's required by state law.
Okay. So you can see there's a lot. I think we're going to have to do a follow-up, Catherine, on 42 CFR. Sort of related as well, there was a couple questions that came in while you were talking, Bob, about the role of a health plan. So let me have you speak a little bit, if you can, to where do they fall? So specifically the questions were if a health plan has a dedicated behavioral health unit with social workers and qualified behavioral health professionals that review and facilitate decisions to a member's care, would that fall under treatment? I think, there's a lot of providers now and FQs and the safety net and the behavioral health systems all now working with managed care plans. So where do they fit in this?
Well, from a HIPAA standpoint, health plans don't engage in treatment, and HHS has provided guidance to that effect. So if a health plan is using information to manage care or coordinate care or engage in quality improvement activities, coordinate treatment with providers, that's generally going to fall under healthcare operations rather than treatment, which is not really material in the sense that both of them fit within exceptions under HIPAA. The main difference is that with non-treatment disclosures, you have to be more careful about the scope of what you're disclosing under HIPAA's minimum necessary rule, so you might be more restricted in what you can disclose. I think that distinction might be more relevant under California law, where, for instance, under the LPS Act, there may be an exception for the disclosure of information for treatment purposes, but not an exception for other types of healthcare operations. And so being able to classify that as treatment might have more significance. I don't know if Jennifer has a view or if the state has taken a view about how health plans fit into that scheme. I mean, I don't think the law is really that specific, and I will repeat Catherine's disclaimer that this is an educational program and I'm not providing legal advice. But, I mean, when I read those laws, I kind of feel like they were designed for healthcare providers and not health plans. But I don't know if Jennifer has, looked at this issue or the state has other thoughts about that.
I think that's an excellent question. We have not looked at the perspective of a health plan with regard to the WIC 5328 exceptions from the confidentiality. So we actually have interpreted this section as essentially all types of treatment, not just mental health or behavioral health treatment. So we do see this as being a provider-to-provider for treatment purposes exception. That being said, we honestly haven't looked at it from the health plan perspective, and that would be something that we're interested in knowing whether or not our stakeholders need us to weigh in on. One of the things that we're collecting is we always attempt to collect and do our best to see what those issues that practitioners have that require us to provide clarification on. So if this is something that the community feels is significant, then we can weigh in on it in our statewide health manual.
Thank you, Jennifer. Let's segue a little bit, and there's several questions also for Alameda County. One in particular, within Alameda, has there been similar efforts to do a reverse model of data sharing, so providing medical encounter data to specialty behavioral health providers? Can you comment on that, Kathleen?
Yep, they, of course, they are asking for that. The technical issue there is that the behavioral health, specialty behavioral health data system does not include a field for who the primary care medical provider is, and they don't always reliably have a way to answer that question. That's just I think it's an indicator of how separate we've been for so long that that's the case. So there's a technical issue there that, of course, they're not going to send the list of everybody they saw to, they need to be able to send a targeted list to the people who are actually taking care of that patient. So we are working on that, and we anticipate being able to resolve it in the next few months.
Okay, great. There was also, it came up under, when you were speaking, whether or not the substance abuse programs in Alameda are considered programs under Part 2. Do you know the answer to that, Kathleen?
The answer is yes. And we actually don't include substance abuse encounter information in the information that we share because of that reason, because it's our understanding, and I think Bob said that also, that even the fact that an encounter occurred with the name of a patient attached is not shareable. So we don't share information from substance abuse contacts, only the specialty mental health side. Okay,
great. What about for children? A couple people have asked, and this really is for you, I think, all three of you. Are there special consents that are set up for children's electronic health records to accommodate for documenting whether they have, and one question was whether or not if they have mental health symptoms but not necessarily a diagnosis. Any special comments you can make about the pediatric side? Maybe start with you.
Well,
I don't think you've seen that in Alameda, right? Kathleen, your project's not focusing on children?
It includes children, but does not focus on children.
Okay.
Yeah.
So are you doing anything special for the pediatric population?
Nope, we're not.
Okay. Bob, were you going to say something on that?
Yeah, I mean, the issue that we have encountered a lot with children has to do with teenagers consenting for their own treatment. I mean, for children where their parents or guardian are consenting for the treatment, then basically the parent or guardian is going to be the personal representative of that child under HIPAA and under most state laws, and would be authorized to sign the consent and direct the use of that information. But what we've struggled with a lot in some of the data exchange projects that we've engaged in is where you have minors, in many states, minors can, above a certain age or who are deemed to have the capability of exercising consent, can consent to their own mental health or substance abuse treatment. And when they do that, they generally control the disclosure of their own information, and certainly parents are not supposed to be given access to that information without the minor's consent. And one of the challenges is that most medical record systems, I would venture to say probably all medical record systems, don't do a very good job of distinguishing when treatment has been provided based on the minor's consent versus the parent's consent. And so when the parent signs an authorization to disclose the information, the provider may have a challenging time figuring out which information can be disclosed because they may not know whether some of that actually was provided without the parent's knowledge and based on the minor's consent, and particularly in an electronic exchange environment where data is being disclosed automatically without human review, it becomes very challenging to filter out the information and figure out what can be disclosed based on the parent's consent.
Okay. Jennifer, did you have anything to add on the pediatric side? Anything unique going on in your offices on that?
I think minors are particularly difficult because of the setup of the way that the EHRs interact and the setup for health information exchanges. They pose, as Bob said earlier, a very special problem because it's not strictly a particular age. In some cases, it's the capacity and maturity of the minor. So because of that, it's very difficult to collect in the system whether or not the patient is the one with the right to consent or, excuse me, to provide permission, or whether it's the patient's representative that has that right. So I would suggest that if you're looking for a way to build your system in terms of your data exchange, to pay particular attention to that piece. Some have decided to not do minors, but that sort of takes out a very viable population for health outcome improvement. So I wouldn't suggest that you should ignore that. I would suggest that you just pay particular attention to risk mitigation efforts.
Okay, thank you. There was also a couple comments about the question of electronic signatures for health records, so that might be something maybe we can clarify on the call. I thought your example was fantastic, Jennifer, about you can obligate yourself to hundreds of thousands of dollars of loans, but in a loan, but it's hard to know if you can give consent to share your data. Do you have any clarification on that, Bob, whether or not an electronic signature is valid?
Well, from a HIPAA standpoint, it is, and HHS has provided guidance. There was guidance that was issued a number of years ago that an electronic signature that complies with the Federal e-Sign Act would be considered a valid signature for HIPAA purposes. But you know, states, I think, are all over the map in terms of where they stand on that issue. I haven't looked at that issue in California, and I don't know if, you know, it sounds like from what Jennifer said, the state has either concluded that it's not permitted or there's some ambiguity about whether it's permitted. But from a HIPAA standpoint, you can use an electronic online authorization.
Okay, that's helpful. And then, as you said, Jennifer, it's something sounds like the state's taking a look at.
Yes. Because of the lack of clarity in state law, the state did implement a few years ago an act that authorized electronic signatures in the same manner that the federal electronic signature for consumer purposes did, but they particularly excluded authorizations in the CMIA, so the Confidentiality of Medical Information Act, which is where the bulk of the authorization law lives in California. So at this time, we think it's unclear. We would like the law to be clear because that's a risk mitigation effort. That's something that providers do not need is a question. We have suggested that the law does need to be changed in that respect, and I'm hoping that other people will take that flag up and wave it strongly. I am not suggesting, however, that they're unlawful. I'm merely suggesting that there needs to be some clarity in this particular place.
Okay, thank you. Let's go back to you, Kathleen. I want to get your sense on some strategies that have been successful in kind of getting to consensus, which you've done so well there, because we have a couple questions that talk about what's the best way to respond to resistance when you've been told that, you know, HIPAA prohibits this from happening. And you know, what strategies have you utilized there, and how did you determine, you know, when it was a good call to go to county council on something versus when you just worked on that relationship box that you had up there on your slides? to get people to agree to share information?
Well, remember that the way we did it was in essence at the leadership level, me as the medical director, my behavioral health counterpart, and our two bosses decided that we needed to do this for patient care reasons. And then we got county council involved, and then we rolled it out to people. So what we were dealing with was the, the ask for forgiveness instead of permission situation. And that's a very different stakeholder management challenge.
Right.
So
and when you go to your county council and something like that, are you basically saying this is what needs to happen from a patient perspective and now you help us execute this versus kind of getting them to give, quote, like you're saying, permission? Is that the strategy you use? Okay.
And they did, we're not doing as full a disclosure as we, disclosure of as much information as we might have if, county council is not willing to sign off on, on license. They worked with us to develop what it is that we could and could not share. And then we took that to the stakeholders and said, okay, next month we're starting this. And then since then, in terms of being able to keep working it through, we've been able, because it's in place, instead of people objecting to what they're afraid might happen, we've been able to actually just deal with actual situations. And the more it's that we're problem-solving real things rather than the people that are afraid of, the more it has become something that people are used to. And they are, they're seeing that it's not really a huge change in what's happening. The patient groups, I think in particular, as is usually true when we first started talking with them about this, they were surprised to find that we were not already sharing data. And I think that's usually true in almost every survey that's done. It's also true of our mental health patient peer groups. And they were, we've been keeping in touch with them, and they are alerted to let us know if they hear of any anecdotes of disclosure or stigma behavior. And so far, so good. So, taking the action, taking the heat on the front end, and then dealing with the real fallout is what has worked for us. And then on the front end, working with county council, asking the question over and over again, what can we do, what can we do, what can we do? That resulted in a small but critical and curated set of data that are available that we can share.
Perfect. So there's been a couple questions, too, and maybe you're in a good position to answer this, about the exchange of information when if a primary care physician initiates a referral for behavioral health evaluation treatment. Can the PCP obtain written confirmation of the care provided, the visits, the medications, et cetera, from the behavioral health specialist without requiring client consent? So I think it's the feedback loop that you've been trying to do there. How do you do that?
I would, given that there are lawyers on the phone, I would defer to them. But it's our understanding that the answer to that is yes. Bob and Jennifer?
And Bob and Jennifer, you want to comment on that? So if a PCP initiates referral for behavioral health evaluation and treatment, can they get written confirmation of the care provided?
I think if it's, I would say if it's for mental health care, I would say yes, because I think there's a treatment exception under both HIPAA and under the LPS Act that would permit that. I think it's more problematic when the referral is being made to a Part 2 program because, excuse me, even though PCP has initiated the referral, the Part 2 program is still subject to the very stringent rules that limit disclosure, and it would probably be a good idea for the PCP to get consent if they want to get a message back from the program they're referring to.
Anything on your end, Jennifer, on that?
I agree with Bob. If this is just mental health care and doesn't involve substance abuse treatment, I would say that yes, provider to provider for treatment purposes is an exception.
Okay, great. So we only have a couple minutes left, but I want to maybe segue to two questions that are in here, and maybe Catherine, even you can share some insight on this too. The first has to do with, again, 42 CFR Part 2, that apparently there are two federal bills that include changes to this regulation. So I don't know if anybody on the call has any information about that. Do you think there's a chance of federal legislative action allowing exchange of substance abuse info, given the support apparently of these two bills, HR 2646 and Senate Bill 1945. So I don't know if, Jennifer, maybe you have some information on that, or Bob, or even you, Kathleen. Anything hopeful for the future?
I think that there's been a lot of discussion around making this information available to primary care and other forms of behavioral health treatment and care. And there's been a real recognition that the stringent disclosure provisions are just not working in today's care models, and that we can really get an improved health outcomes through sharing. And I'm talking about appropriate sharing. So treatment is an appropriate method of sharing. That would be an appropriate reason for sharing, not just because everybody wants it, but we're talking mainly about that. So I am hopeful. There's been a lot of discussion. We've weighed in on that, seeking those changes to occur to be more in line with other protected health information, and so that we, with the state, can share our information in a more effective manner to obtain those health reform goals that we're all very working on very hard. Thank you.
Yeah, I'm not that close to the the lobbying effort in Washington. The last thing I heard was that the likelihood of the legislation passing was low.
Oh, okay. And then, Jennifer, kind of on your point. I'm sorry, Bob?
No, I'm sorry. Go ahead.
Oh, okay. I'm sorry. I thought I cut you. About the comment that you made about how long it takes for things to shift, for a regulation to get adjusted. Is there any thoughts you have about how those who are participating in the call today, what they can do in the interim? Is there a role they should be playing to help move that dialogue along, or those changes along, and expedite those kinds of processes?
I think that's an excellent question. This is not going to be something that, it's going to be a little bit more on the holistic side, the response I'm going to give you on that. So I do think that providers need to comply with the law, but they also need to comply with the ethics and the standards of care in their profession. So if the law fails to support those ethics and the standards of care, either because it's unclear or because it supports an outdated standard of care or an outdated guiding principle, then I do think that providers have a responsibility to help move that change through either contacting their professional organization, an advocacy group, their ethics organization, or their, frankly, elected representatives. We, like I said, in the state agencies don't make law. All we can do is pass that along and do our best to hear what you have to say and to move our courses of action and our guiding principles in a consistent pathway to meet yours. But we don't get to make those absolute changes that the legislative branch gets to make. Regulations take a long time, but they're also based on statutes. So again, those are really implementing the legislative enactments into law. So what I'm encouraging you to do is to really move that conversation with the professional organizations, those organizations that have some political clout that can actually get those changes made.
Great, great advice. So Catherine, I think we'll turn it back to you, and a couple people asked sort of what's next on this horizon, and then, want to reassure everybody we will try to get back to them on all the questions that we didn't get to today. So thank you everybody for your answers and your questions.
Thank you very much, Mary. Thank you so much to our panelists for your time and your comments here today. This is very difficult work, and we hope that today's presentation has given you some helpful information, even as we know that there are many outstanding questions, the ones you've typed in and the ones you have not, but still have in your heads. From our end, from the California Healthcare Foundation, our next steps include continued work with our colleagues at the state level and at the local levels to shed more light on these issues and to try and continue to chip away at this barrier to integration. So with that in mind, we continue to be interested in hearing from you out there about what kinds of information, additional topics or tools or resources, whether those are, through publications or additional webinars or possibly in-person presentations to organizations or at the regional level. Please let us know what sorts of things would be useful. We are really grateful for your participation here today and also for your work on the ground to continue to move integration forward. And I'll leave you with one last slide, which has contact information for the presenters, as well as for Jennifer Martinez, who works with Dr. Clannon in Alameda County. I encourage you to let us know how else we can be helpful. And as we've mentioned, the recording of the webinar, as well as all the slides, will be posted within the next couple of days at chcf.org. So thank you very much, and enjoy your afternoon.
Ladies and gentlemen, that does conclude today's webinar. You may now disconnect your lines.